my talk today is about estimating the returns to health-related spending. So it's actually somewhat related to what Jessica presented, but in other ways, this talk is kind of now time for something a bit different. And you'll see what I mean as I go through it. We're going to see a lot of regression outputs and that kind of thing. So absolutely need to say that this has been collaborative work with others. Sometimes I've been the lead author, sometimes others have been the lead authors, and mostly thanks to Carl Claxton and Francesco Longo, and in particular, Steve Martin, who is really the driving force behind all of this work and unfortunately passed away recently, far too young. So this is dedicated to Steve. Okay, before we get stuck into the UK context and perhaps the slightly unfamiliar, I thought I'd just kind of ground this in the sort of broad conceptual area that it fits into. And conveniently, Jessica also used a slide very similar to this, where she represented the health production function. And that's what all this work is really about. It's about how much does it cost to produce health via different forms of spending, but in particular, I'm going to focus on healthcare expenditure. So it really is the sort of classic health production function. And when we're looking at the returns to health-related expenditures, what we're really looking at is the slope of this health production function at any given point. Just to kind of give you a little bit of advance notice again, sometimes rather than thinking of it as the slope of the sort of health gain for a certain amount of expenditure, we often present it the other way around, the inverse, where we talk about the cost of producing a unit of health, the cost of quality adjusted life year, for example. So I'm going to talk about this in this talk today. Okay, now what I'll get back to at the end, but I wanted to just kind of plant the seed first and foremost in this presentation, is to say that this is a really useful question for policy. This isn't just an abstract question relating to expenditures and outcomes from your economics textbook. This has material policy implications, and it affects, I'll explain later how this affects not just the size of the pie, i.e. how much we're going to devote in terms of resources to healthcare or other forms of health-related spending, but also how we divide up those pies in terms of how much are we going to allocate to different types of healthcare spending and so on. So it has implications for both of those questions at the same time. So it has been quite important in UK policy areas. Okay, so let's get into what I'm going to talk about in this presentation. And this is where we kind of start on the journey, which is very much UK-centric, but I hope to be able to explain all of the key terms and acronyms as we go along. So I'm first of all going to talk about healthcare expenditure. That is, in the UK context, healthcare expenditure by the National Health Service, which is a public healthcare provider. I'll talk a little bit more about the UK context in a moment. So I'm going to present different analyses that we've done, kind of showing how the studies have evolved over time in terms of the identification strategy that we've used, but also how we've responded to the policy environment and the institutional background changing a little bit over time as well as more data has become available. Then I'm going to talk about health effects of a health-related expenditure, but not healthcare expenditure per se. Instead, thinking about public health expenditure in the UK, because as of about the last 10 years, this is no longer a form of NHS expenditure. This is handled by local governments. So it's quite separate. And then we'll also look at the effects of social care expenditure. Again, not part of the NHS, but clearly a very important form of expenditure that can have health effects of different types, and we'll talk about that later. And again, this is also something that's a responsibility of local government. So it is public, but it's not part of the NHS. Finally, I'll talk about okay, no problem. Okay, that might be a bit clearer. Okay, excellent. So I was just finishing off my outline slide. So first of all, talking through the different types of health-related expenditure and what the health effects we've estimated of those to be. First of all, NHS, healthcare expenditure, then public health expenditure, which is the responsibility of local government. So it's public, but it's not part of the NHS. And finally, social care expenditure. Once I've gone through these results from published papers, I'll then talk a little bit about the work that we are currently working on or that we are planning to work on before kind of rounding off with some policy implications of this work. Okay. So this may be familiar, it may not. I thought it was just worth including one slide to kind of go over this. I've already touched on some of it. The National Health Service has been going for some time now, 75 years old this year. Its birthday was quite recently. And yeah, it's still going. Healthcare is provided free at the point of use, both in terms of primary and secondary care. Now, private healthcare can be purchased separately, but this is quite a small share of the market, as it were. So a focus on the NHS as the main source of healthcare expenditures is justified in the UK context. Now, importantly, and this is really important for the kind of work that I'm going to present, is that we have a national budget for the NHS, but then this is devolved to different geographic areas in terms of what care can then be spent on. So even if the commissioning is done centrally, there's still a local budget that is determined nationally in order to kind of devolve those resources down to the local level. In some cases, the local areas themselves control what is commissioned. That's increasingly the case. So local areas have more control over what care they're able to purchase from their budget. I'm also going to talk about other types of health-related expenditure that are not within the NHS. So adult social care, responsibility of local authorities, and public health, responsibility of local authorities, at least since 2013. So for some time now, but not historically the case always. I think it started with local authorities, then got brought within the NHS, now has been put back out to local authorities. Okay, so thinking about for the moment, healthcare expenditure and age standardized mortality outcomes. If we're to think about a statistical association between these two variables, we've got a bit of a problem in the UK context. Why that's the case is illustrated quite clearly in this graphic here. So it's actually quite historical data here, but on the left-hand side, you can see the amount of money that each local area spends per person. I won't get into the acronym that's given there. Let's just keep it at local area. So left-hand side is how much is spent per person. Right-hand side is the age standardized mortality rate. Now, you can't do the regression in your head of one against the other, but what you can probably see just by eyeballing this is that there seems to be some sort of positive association here. Areas that spend more on healthcare have higher age standardized mortality rates. So a pure statistical association of these two variables is going to suggest higher spending, higher mortality. And if we were to be very naive in interpreting that, we might say, well, healthcare is killing people. Now, of course, that's not the case. And it begs the question, what is going on here to drive this result? Because this isn't always what we observe in all countries when we just look at the raw data. Well, the reason for this is that each area's budget, so when they devolve the national budget to local areas, there's a formula for deciding how much budget each area should get. And this formula depends on sort of 4 factors. You can break it down into these 4 factors. The first one is the sort of age demographic profile of the local area. And effectively, the older the area, the more money is allocated to that area in order to deal with those health needs. In addition, there's an additional needs index. This is B on my list here. And this will reflect other factors as well beyond just age and sex. So this will reflect factors such as local deprivation, for example. Another important thing is how much do prices vary across local areas. So it might be that input prices differ and we need to give more money to areas where the input prices are higher in order for them to be able to meet healthcare needs. And that's C. And then finally, and this is the most nuanced one of this list, there's this distance from target index. Now, this is a bit of an intricacy of how the funding is done, but it is quite important actually in terms of how much money each area gets. So let me just give you the rough intuition of this, because this is quite a key component of this formula for the analysis that follows. Basically, parts A to C will determine how much we think an area needs to meet the healthcare needs. And that will give us a target allocation for each area. In a sense, that's how much money do we think the area should have given the healthcare needs we think it has. However, we periodically revise that target. We use new methodologies, better methodologies, hopefully, as we go through time. And also, there's just no general guarantee that that target that we estimate in any given year is anywhere near what that area is used to receiving. And as a sort of policy response to this, it's viewed that we shouldn't just transition areas to what we think they should have immediately, but rather we should smooth it over time, transition it so that they move gradually from what they currently get to what they should get over a period of time. So because of this transitioning, some areas actually end up with quite a lot more money than we think they should have, and other areas have quite a lot less money than we think they should have. It could be of the magnitude of 10%, let's say. It's not trivial. So these are the 4 factors that ultimately determine how much budget each area will have. The first 3 relating to needs and input prices, and the last one regarding this transitioning policy called the pace of change policy. So because of parts A and B there in the previous slide, this is why we get that positive association between healthcare expenditure and mortality, because particularly part B, when we're thinking about additional needs, deprivation, it's deprivation that drives the fact that money is allocated to these areas, and it's deprivation that drives the fact that mortality rate, age standardized mortality rate, is higher in these areas as well. So there's clearly going to be this sort of built-in artifact relationship that drives these to be positive. And in the sort of broader economics literature, we can think of this as a sort of reverse causality problem or endogeneity, and we need to be able to account for that. It's the wrong way. So we deal with endogeneity in the way that is often done in econometrics literature. We've done what can be loosely described here as a DAG to try and explain the causal relations. And basically, what we're aiming to do with our econometric strategy is to cut out the unwanted directions of influence. So that's the one that goes from mortality to expenditure and from an unobserved confounder to expenditure, and to be able to isolate the desired direction of influence that we want to estimate, which is what's the effect that healthcare expenditure is going to have on mortality. So we need an instrumental variable to be able to do that, an instrumental variable that predicts actual expenditure but isn't related to mortality and isn't related to this unobserved factor directly. So if we go back to 4 factors, we actually use 3 of these 4 factors as IVs in our context, as potential candidate instrumental variables. So the first one I'll talk about is this distance from target index. So it's a result of a series of policy choices over time. It's not obviously related to mortality. It's not going to be obviously related to unobserved confounders either. So that's quite a good candidate instrumental variable, particularly if we condition on various confounders in our analysis as well. Prices in the local health economy, I think conditional on controlling for things, this can also be potentially exogenous source of variation, because again, this factor won't be influencing mortality directly, but it will influence how much is given to each area. The age cost index, you might not think that this would work very well as an instrumental variable because age and mortality are clearly related. But remember that we are looking here at age standardized mortality as our outcome. And because it's already been sort of taken account of the age effect on the outcome, this is quite a good instrumental variable, because again, it is used in the formula to allocate between areas. So we can be reasonably confident that it's going to be a good predictor of expenditure. But because age and mortality, that direct effect has already been taken account through standardization, it's plausibly a valid instrument. But the one that we can't include is this additional needs index, because this is really a big cause of the endogeneity. We want to be able to isolate that effect and remove it from influencing the estimates that we observe. So this, in essence, these three green highlighted variables, these are the candidate instrumental variables that we're going to use in our analysis of NHS expenditure. And we'll use this sort of data generating process to try and get at causal estimates of the effect of health expenditure on health outcomes. Now, I'm not going to go into great detail on this slide, but you'll see in this presentation that I'm going to present results in terms of QALYs, but so far I've only talked about mortality. So quite a lot of work has been done to go from an estimated effect on mortality to an estimated effect on a more comprehensive measure or a generic measure of health, such as the quality adjusted life year. I'm not going to go into that in great detail, just to say at this point that, you know, there's quite a bit of work that's been done on this part alone, on how that's extrapolated. And it's been sort of tested to some extent through elicitation exercises as well. But it's clearly a very important part of the work, and I will be talking quite a lot about results in terms of cost per QALY. Just bear in mind that some process has been undertaken to get to there. So indeed, let's first of all look at the first results that were published in this area. So these results are based on 10 years of data from 2003 to 2012, and they were using an approach, actually not the one that I just explained, but something that was a sort of precursor. It used more a pragmatic approach to instrumental variables that had less of a conceptual basis, but these are the ones that are published in the HTA report by Claxton and others, published in 2015, that have been very widely cited. So we kind of extended that analysis to 10 years of data, and this is what we got. And the results were similar to what that very widely cited report were presenting. So really, this is a story of, we presented results that are consistent over those 10 years. And what this work has been summarized as saying is that actually it looks like the NHS spends something like £15,000, or the weight of evidence is they spend less than £15,000 to generate one additional quality adjusted life year. So the implication of that is if you gave the NHS an additional £15,000, on average, they're going to produce one quality adjusted life year out of that. Or flip it on its head, if you were to cut £15,000 from the NHS, you're going to lose one quality adjusted life year that you would have otherwise had if you hadn't cut that amount of money. So this was a sort of older identification strategy approach, as I suggested. But when we later applied this funding rule approach, where we use those three green highlighted variables as instruments for healthcare expenditure, and applied it to the same data between 2003 and 2012, you can see that these red squares are actually really quite close to those blue diamonds from that earlier study. So in some ways, have more confidence in these red squares because the instrumental variable approach has more of a conceptual basis, an intuitive explanation as to why the specific instruments work for this context. And you can see that again, basically these results are broadly consistent with one another. If anything, I think you would say that the red square results here with the funding rule IV, they were producing slightly lower costs per QALY for the NHS. And certainly strong evidence again that it doesn't cost as much as £15,000 per quality adjusted life year. So the reason I emphasize this £15,000 is because that's the number that the UK government uses when conducting impact assessments. So when it's thinking about policy that's going to affect resources available to the NHS. They will use the fact that they think that on average, each £15,000 is going to translate to roughly one quality adjusted life year forgone. So yeah, the evidence is that it looks like it's definitely less than £15,000, certainly not more than, but perhaps less than. Hard to say, really. So one thing I wanted to note is that these studies, in order to get to quality adjusted life year, this isn't just a single regression that is undertaken with healthcare expenditure and age standardized mortality. This is done by disease area as well. So we have heterogeneity in the effect of healthcare spending on mortality by disease area, and then these are then aggregated at the end in order to inform an estimate of cost per quality. And that's done in both of these studies that are presented on this graph. We also did some other work which looked at whether, given the fact that there are 10 years of data available, would it be better to analyze these as a single panel rather than to go into each data set as if they were independent, one year after another. So that's what you can see here. So we've got the same results as before, presented with the blue dot, but then we also estimate an IV model when we've pooled all of those years of data available as well. And you can see that the orange dot is surrounded by much narrower confidence intervals, and that's absolutely to be expected because we've pooled 10 years of data, 10 times as many observations now in our regression. But the point estimate is more or less unchanged. So, this analysis is, again, another story of confirming original results. We were also kind of criticized for analyzing each year of data independently. And the suggestion was that basically we're overfitting our models by going into each year and optimizing an IV model, and then going to the next year, changing the covariates and optimizing it. So there was this concern that we're sort of overfitting the data, and that perhaps this was causing some sort of issue, perhaps in terms of point estimate, but also in terms of the confidence intervals that resulted from this approach. So we wanted to investigate this. So what we did was we fitted our panel model that I explained earlier that runs across all 10 years, which is the orange dot. And we just ran that single specification to each year, whether or not it passed our diagnostic tests for an IV model, and then reported the results from that, just as a check on this idea that we're overfitting. Didn't really find all that much, particularly. It kind of looks like the forced model, as we call it, kind of increased the uncertainty, but not in a major way. We argue that actually it makes sense to do each cross-section separately because, to an extent, these are different populations that we're analyzing. The UK population changed a lot over these 10 years, and it's not clear that we should use the same variables necessarily in each analysis. But there you go. We did it anyway, and we found that it produced more or less the same result. So with these 10 years of results available, it begs the question, what do we think is going on over time here? And you may have seen from the graphs, there's a sort of upward trend, I would say, from the results. So the cost per quality of NHS expenditure was increasing year on year. And this graph actually shows that in real terms here, because we've got 2012 prices displayed on the graph. And you can see if you look at those results, 2003 to 2012, it is steadily increasing over time. So that's one thing. And then, of course, because we're looking at historical data, whereas policymakers want answers for today and tomorrow, not yesterday, they wanted us to say, well, what does that trend mean in terms of what we'd expect for now or in a few years' time? At that time, they were interested in 2025, which was about 3 or 4 years into the future. So what we did was to do something quite crude, but just to sort of say, well, if this trend continues, you can see that, roughly speaking, in 2012 prices, we would expect the cost per quality to be about £12,000. But at 2025 prices, taking account of inflation, we would expect that cost per quality to be about £14,000. Again, still below £15,000, and this was therefore quite supportive of the Department of Health's policy of using £15,000 as an estimate of health opportunity costs. Now, what have we found since we've started analysing more recent data subsequent to this projection? We have found that these projections seem to be a little on the high side compared to what we've been getting from more recent estimates. So here you can see big red square that indicates our 2016 estimate of the cost per quality of NHS expenditure. And it's actually considerably lower than what we were projecting on that dashed line there. It's not so much lower so that the confidence intervals aren't overlapping at all, but it's still, you notice that it's a little bit below trend. So let's have a look at the more recent estimates that we've been producing and have a think about those and how they were generated. So that was 2016 I put up on that graph, but we actually, first of all, did an analysis with 2014. So here's where we need to start talking a little bit about changing institutional setup. 2003 to 2012 was all at this pretty much the same level of geography in terms of what defined a local area in the NHS. In 2013, there was a total change in terms of what local area we were looking at. And in came the clinical commissioning groups to replace the primary care trusts. In some cases, not very different, right? There's still kind of cities and towns recognized, so there's some overlap between the definitions, but in other ways, quite different. And in particular, what's quite different here is that there's a change in the functions that the local area is going to be responsible for commissioning. Clinical commissioning groups are basically commissioning what we might think of as hospital care, okay? So this analysis here is looking at the cost per quality of NHS hospital care, secondary care. It's not exclusively that, but it's not far off. It's probably best to think of this variable of expenditure as being secondary care expenditure. If you remember, it's around this time that public health was also taken out of the NHS. So this clinical commissioning group expenditure will include no public health activities. In any case, what do we find? Well, we find here across a range of different econometric specifications, a result of about £6,000 per quality. Okay, so that you can see here in these three columns, it's just £6,000 to £7,000. And then last column is just there to compare with the most recent result from the previous batch of results that I just presented. So it kind of looks like it's fallen. It's not exactly clear why that is. It could be because of the change in the definition of expenditure that's being analysed, but it could also just be because of some other factors underlying what's at the margin in the NHS or what's going on with the budget for the NHS. Because during this period, it was kind of had been stalling really in real terms compared to what it had been over that 2003-2012 period when things were growing quite rapidly in terms of NHS resources. So those are the results that we got. Let me just quickly talk about the differences here between the specifications in the three columns. Previous work, I kind of mentioned it earlier, there was this criticism about us choosing covariates. And what we'd done was basically done a sort of backwards selection, stepwise regression approach. So we just started off with a lot of variables, and then if they weren't significant, we'd excluded them. So the reason for doing that was we've only got about 150 local areas in any of these cross sections, not loads of observations. We don't want to be including absolutely loads of regressors, so that's why we've done that. But people say that it has problems in terms of inference and in terms of bias, so we wanted to show that actually in this analysis, we'd taken on board that criticism and we moved to presenting a range of different approaches to covariate selection. Column 1, don't remove any covariates whatsoever. Column 2, follow the approach that we'd used previously. And column 3, use a lasso approach to covariate selection. So it's a sort of machine learning inspired approach to deriving the suitable regression. And this also corrects for the standard errors in an appropriate way as well. Basically, we found that the results were consistent, irrespective of the approach taken. But I just wanted to give you a flavor of how the work's evolved and how it's responding to criticism over time. Okay. This work also looked at distributional effects. I won't go into this in great detail, but if you just look here across the top row, you can see that quantile, the 15th percentile, actually has a positive but insignificant effect on mortality. 25th percentile, it's negative, but again, insignificant. And it's only when you get to these higher levels of mortality where you see really significant effects of healthcare expenditure. So what this is suggesting is that healthcare expenditure at the margin is having more of an effect in areas with higher mortality rates to the more deprived areas. In other words, cutting money from the NHS is likely to increase health inequalities. That's the key finding from this paper. But I won't go into detail on this point, just in the interest of time. Okay, what I did want to spend a bit more time on was this 2016 analysis. I already mentioned it earlier. It comes out with a result that's about £6,000, £5,000 to £6,000, which was quite strikingly low and also more consistent with that 2014 analysis than with the analysis beforehand. Now, this is somewhat surprising because this analysis was where we now had data on different types of spending in the NHS. So we've got not just that hospital spending, but we've also got primary care spending and also what's called specialized commissioning spending, i.e. spending on specialized services. So that's really interesting. So what this shows here is that actually underlying that difference is probably something more to do with changes in the budget, changes in what's at the margin, rather than to do with the definition of expenditure, because now we're seeing that we are still getting results that are lower than previously, even though we've included all of the different types. But more interestingly, I think, this new data gives us the opportunity to explore the heterogeneity in the effect sizes of different types of healthcare expenditure on mortality. And kind of cutting to the key results here in the interest of time, you can see that we're replicating more or less the work from 2014 that finds about £6,000 per QALY for hospital expenditure. That's the first three columns here. But then we're finding that actually primary care looks like it's really cost effective in this analysis. So the elasticity that you can see here of 0.4 is lower in magnitude than the elasticity that we get from hospital care. But primary care is a lot smaller chunk of the budget in the NHS than hospital care, a lot smaller. Primary care is something like 5% of the overall budget, whereas hospital care is like the majority of the budget. So you have to bear that in mind. So for every 1 percentage point of hospital expenditure, that's a lot of pounds. 1% of primary care expenditure, that's not many pounds. But then these elasticities are about percentage points in mortality, which is the same for both. So we're actually getting much more bang for our buck, and that's reflected in the cost per QALYs here. You can see that primary care cost per QALY is close to £2,000 compared to £6,000. Therefore, on the face of it, seems much more cost effective than hospital expenditure. It is a bit more uncertain, though, in our analysis. I won't show that in great detail now, but just take it from me. It is more uncertain, and that's not unexpected because the link between primary care and mortality, there's a lot of steps that lie in between that. And so we would expect some noise in our analysis. We would expect sort of relatively large confidence intervals. These middle three columns on specialized commissioning, what they're effectively showing is that we don't find a significant effect of this type of expenditure on mortality. If you put it in terms of cost per QALY, it looks like it's quite expensive. It's kind of care. So I'm going to have to go really quickly now. We started then to look at the analysis outside of the NHS. We looked at public health expenditure, and we had to use an instrumental variable approach for this as well. And for this study, it's very similar. So the public health budget also follows a formula, and we're able to separate that out into exogenous and endogenous parts and just use the exogenous parts as the instrumental variables. What this study showed was that public health expenditure looked really quite cost effective compared to hospital expenditure in this case. We kind of build this as a prevention versus cure study. We found that while an ounce of prevention wasn't worth a pound of cure, which is something like 16 times as good or something, it looks like it's about 3 to 4 times as cost effective prevention is, i.e. public health expenditure compared to hospital expenditure. Okay, and then we expanded that work to look at social care as well. And we found a rather striking result in the sense that social care expenditure is having a really big effect on mortality. We didn't necessarily expect that. And the reason we didn't expect that was because social care doesn't really aim to reduce mortality. It's much more about improving quality of life. So this provided a whole new seam of research for us as we tried to work out what could be underpinning this very strong result. I'll jump straight into that. So we've since moved into a study where we tried to investigate the interactions between sectors. The hypothesis is that social care is making healthcare more effective, and that's why we're getting such a big coefficient on social care. And when we look at this analysis where we've tried to investigate the interactions and sort of interdependencies between the effects of these two types of spending, we find exactly that. So if you just focus your eyes down on marginal mortality effects here, in this paper, we argue, I think quite convincingly, that healthcare does not have an indirect effect on mortality. It doesn't affect the effectiveness of social care expenditure. It just has a direct effect on mortality. Healthcare saves lives. In contrast, we find that long-term care, which is a form of adult social care, doesn't seem to have a direct mortality effect at all, but it does have this substantial indirect mortality effect. So exactly the hypothesis was kind of mirrored in the results that we were able to get from this paper. We've also done work where we investigated the effect of social care on care-related quality of life. This is the one where we did expect to find results because this is what social care expenditure is supposed to do. And we do find an effect. But it does seem to be reasonably small. And what this kind of points to is the fact that social care is having an effect, but it's quite a complicated picture because there's the effect that social care has on people receiving care. There's the effect that it has on improving healthcare expenditure. And there's also the effect that it's having on carers' care, because you have a lot of informal care in the UK. And we think that spending money through local government can relieve that caregiver burden and improve carers' quality of life as well. So that's some ongoing work that we're working on now. All of these different pieces need to come together to realize what the full effect of social care expenditure is. So we've started to do those little pieces, and now we've also started to kind of put them together as well. Skip that one, I think. So, yeah, I think that's a good point to pretty much stop and just first of all talk about what we're planning to do next. Of course, always looking to sort of update our analyses with new data as it comes in. And that's quite interesting in the UK context because politics changes over time and lots of different things have been done in terms of the level of expenditure in the NHS. So that's quite an interesting thing to bear in mind. Also, we're keen to look at heterogeneity in a bit more detail now that they've started to give us that data broken down by different types of expenditure. I think the key limitation of this work, in my opinion, is that it relates inputs to outcomes, but it doesn't tell you how it happens. So it's a bit of a black box underlying how healthcare expenditure is improving health outcomes. And so there's some work underway where we try and look at what kinds of healthcare activities vary as healthcare expenditure varies. Some ambitions to kind of do some other types of panel analysis, wanting to look at how the effect size changes with different sizes changes in expenditure, basically trying to get at that sort of diminishing marginal returns function that we think exists. But we also want to look at public health expenditure too. Similar to what I was saying with social care, we think that public health expenditure is not just about mortality, it's about other things as well that may have nothing to do with mortality. For example, quite a lot of public health expenditure is on sexual health services. It's unlikely to have a huge mortality effect, but we might be able to see outcomes specific to that kind of expenditure where there is a substantial effect, and where variations exist across areas, maybe variations exist in those outcomes as well. And then I already touched on this one a bit about adult social care expenditure, really trying to understand what's going on there. Adult social care expenditure is a real sort of live policy area in the UK. It's one that's being debated heavily with each election and will no doubt be a big part of the upcoming election as well. So, trying to get a handle on how adult social care expenditure works, what it does, and how important it is really important for informing that debate. So, I've gone into some detail on a wide range of studies that we've done on these questions. And I just wanted to quickly reflect on why I think it's interesting, but I will be very quick. Firstly, I think that we need to think about what health effects are of changes in health-related expenditures, both for cuts, but also investments. Governments may come in with different ambitions, and so it's important to think about what those are. I also think that this analysis starts to tell us a little bit about how we should allocate resources within healthcare and more general sort of health-related expenditures. We find strong evidence that the sectors are interrelated. There's a greater push for integration of these sectors as well, so between like social care and healthcare, for example. And so understanding those interdependencies will be really important. There's evidence that prevention is better than cure. That probably won't surprise anyone. I think people have been saying that for some time now. But we're starting to put some numbers on that in the UK context, which has been quite useful in determining how much budget gets allocated to public health, for example. And again, on the issue of health inequalities, which is a really important issue, it does seem like how much we allocate to different areas will have an effect on geographical inequalities, but also possibly socioeconomic inequalities indirectly as well. And then finally, coming back to the topic of Jessica's presentation, we can also use this evidence to inform what the net health effects will be of specific health technologies and interventions. Because when we commit resources to specific interventions, we take money away from the budget that could otherwise have been used for other things. So using this evidence of health effect of care at the margin as a form of reflection of health opportunity costs can be really important. NICE spends more than £20,000 per QALY on new interventions and regularly commits the NHS to spending that level for a unit of health gain. But it's quite clear, looking at our evidence at least, that the health opportunity cost is better reflected by at most £15,000 per QALY. So there's some sort of disconnect there that is policy relevant. And the UK government has sort of used this analysis as part of impact assessments, as I mentioned before, to use £15,000 as the rate of health opportunity cost. But it also underpins some rebate schemes regarding branded pharmaceuticals as well, reflecting the fact that we're probably paying too much in the first place for these new drugs. Okay, all of the studies are provided here in references, and hopefully I've given you a taste for looking a bit further at the details, because I know I've mostly only presented the results, but thank you very much for listening.